Hey, folks, this is Ray Cobra coming at you. So we are doing something new here. We are taking an interview and breaking it down into a three-part series. So I had the privilege of interviewing Mr. Woody Waters, one of the founders of what we now know as reference-based pricing. You'll learn that they didn't call it that back then. That kind of evolved. But he's one of the original founders of ELAP. They, of course, were acquired by Imagine 360. But you'll get a sense of kind of where this all comes from. I know that there are many folks that have, hear the acronym RBP or reference-based pricing, and they really, it's kind of foreign to them, right? A lot of that in the insurance business, a lot of these acronyms that are nonsensical or abstract. Well, in this talk, Woody will break it down for you. And so without further ado, this is the first of a three-part series. I hope that you enjoy listening and watching as much as I did interviewing Woody Waters. And so here we go.
Get ready to take control of your healthcare. Here's your host, Ray Cobra.
And we're live. Ladies and gentlemen, welcome to Broken Healthcare. My name is Ray Cobra. I am your host, and I am delighted to have with us in the studio today, some say the father of RBP, reference-based pricing, Mr. Woody Waters. Welcome to the big show, Woody.
Happy to be here, Ray.
Yeah, it's great having you. So tell me a little bit about, I like to get to know my guests. As I get to know my guests, my audience gets to know my guests. How long have you been in this game?
Well, I've been in the insurance business my entire career. So starting in 92, I was a broker for the first 9 years, and then I've been at what became reference-based pricing ever since. So that would be 92, 33 years.
33 years.
I was told there would be no math. So.
Yeah, and I can't claim to be the greatest at math, but... Yeah. Today happens to be my son's birthday, and he was born in 92, so there's quick math for you.
There you go.
So 33 years. Was insurance in the family? Was it a family business? How did you find insurance, or how did insurance find you, which is typically the way it works?
It found me. Uniquely at the time, I think this is true of many more business schools now. I went to the University of Georgia. Within the business school, you could be a risk management and insurance major. I was a finance major. The head of the insurance department came to speak to our class on what ended up being kind of a recruiting mission. And the guy was a very engaging personality, and he assured the class that day that if you were a major, he'd help you find internships, help you find a job, so on and so forth. I kind of was in finance and banking just because anyway. And I thought what the guy, he made one point I'll never forget. In fact, I use it, that insurance doesn't slump. It's a need, not a want.
Right.
All the things that are true. And so I went to see him in his office in the next couple of days, and he had a book with internship offers on his desk, and one was in my hometown at a broker firm I knew, and I ended up being an intern there that summer. Learned how to prospect, stuff like that. Finding X dates was a big part of my internship. So
finding X dates?
Yeah, like they gave me a stack of leads in certain industries that they were interested in. And with a host of questions, all they wanted to know was when the insurance renewed.
Got it.
So I would find out when was the renewal date, who primarily handled the insurance, how far in advance of that renewal date did they want to start. And so by the time I left at the end of the summer, I left 3 producers there with a pretty good Rolodex.
Right on.
Yeah.
So, if I were you, once I would have learned that they all pretty much start on January 1st, I would have called it an early day.
Right. That's the thing. This was on the property and casualty side. So they did start some on July the 19th, some on September 14th, and so on. So,
got it. But, it really brings a good point, which is insurance really is not optional, right? Your Insurance 101, what's the purpose? It's to avoid catastrophic financial loss.
That's right.
Right. That's why you have insurance, and it works the same way in healthcare as it does in property and casualty. Although you wouldn't exactly know it the way our health insurance is designed these days.
Right.
And so, when you left there, where'd you go?
I went to work for a regional firm, a broker firm down south. They had offices in Alabama and Georgia. And while I was there, they made acquisitions and grew into South Carolina, Tennessee, Florida. I was there for 9 years. By the time I left, they were in Mississippi, North Carolina. Now they've been acquired by Marsh, and so they're probably the biggest office down south of in the Marsh orbit.
Shocking.
Yeah.
A brokerage that was acquired by Marsh?
Yeah, that's right.
Who would have thought? Being facetious, of course, all of the M&A that's going on in our space is crazy, right? It's a lot of the small shops are being gobbled up by the big shops, and there's a reason for it. Like we've been solicited, for my small brokerage,
Sure.
and there's a reason why, these people come knocking, and that's because your business is very valuable. People rarely make change. If you're doing a good job and you're providing good service, they generally stick with you. Like the average persistency for a broker is 6 years, according to Marshberry. And so, if they can make an investment for 3x, 5x your business, odds are they're going to recoup their investment and then some. So we're seeing a lot of M&A going on in the space. So at what point was there this kind of pivot? Did you leave that firm then and strike out on your own, or did you partner with someone or join another group, or where'd you go from there?
I had a partner, Steve Kelly, and we remained partners until December 31 of this past year. He retired.
Oh.
We had taken on at Imagine 360 private equity coming up on 9 years ago, and so Steve's 13, 14 years older than I am, and he just crossed the retirement Rubicon. So we have the same private equity investor partner as 9 years ago, and he, aged out.
Right.
So
sure.
He and I met in the property and casualty business. We did a lot of business together.
Okay.
And it's a long story that I'll Seinfeld yada 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 a little bit, but he's from Philadelphia, and he got caught in a non-compete spat. Pennsylvania is one of the only states that really enforces them. And so he kind of was locked out of the property and casualty business. He started a stop-loss MGU, did really well in it. And he noticed, that property and casualty is highly regulated, highly standardized, probably the biggest difference between it and self-funded health.
Mm-hmm.
Very, very standardized, policy language, forms. And anyway, he saw in the self-funded health space, a big gap in standardization and standard operating protocols, a business-like way of doing things. And so after he'd run the stop-loss MGU for a while, this is when right around 2001, when the Department of Labor passed that original Claims and Appeal Act that did standardize some of the decision-making and appeals process. And so we built a program around being a co-fiduciary to a self-funded plan and making decisions at the final level of appeal and accepting liability and responsibility for those decisions. And so that was the groundwork for what 5 or 6 years later pivoted into reference-based pricing.
Okay. And so this gave you kind of his epiphany was there's an opportunity here, right?
And there's no standardization.
The P&C space is much more standardized and structured. The healthcare space, health insurance industry is more like the Wild Wild West.
So in 1, 2, 3 order, what we noticed is, and again, this piggybacks on when the Department of Labor put that Appeals Act in place. It was July 1. It went live July 1, 2002, and by January 1, 2003, as you renewed, everybody had to comply. And so it was you could have one level of appeal or two. At the second level, you had to consult external review, bring in independent review agencies to double check the decision. And then it was final. And if the member thought you got it wrong, they had a right to sue under ERISA. But what Steve and I realized is the Maalox moment instances, the things that caused a lot of grief. Well, first of all, the TPA didn't want to make the decision. The group, all of them understand being financially self-funded, They don't understand that they've taken on the role of being the insurance company and having to make these final decisions that impact valued employees' lives, right? They don't want to make the decision. Stop loss carrier doesn't want to make the decision. They all want to influence the decision, but nobody wants to make it finally and own it. And so we saw a void in there that we could fill. And then we saw the painful decisions being made over experimental, over medical necessity, at the time over the new procedures that were around morbid obesity, gastric bypass and all that, illegal acts. There's a car wreck in the middle of the night, kid's been drinking. Can you invoke the illegal acts exclusion or can't you? So we seized control of 5 or 6 definitions in the plan document, and also of the exclusions that went along with those. We had an ERISA attorney write that language for us. We had about 7 pages of Department of Labor compliant language. So if an average plan document was 100 pages long, we were going to give you 12 or 15 pages to put in there and say, if you want to buy from us, if you want us to make this decision for you and assume liability for it, you have to use our language.
Our language.
Yeah.
So do you recall specifically, I'm trying to wrap my head around what changed. So before 2001 and after 2001, if you were an employer that had an insurance plan for your employees, what was different before and after?
Well, a TPA we now own in Dallas, Texas, at the time called Group and Pension Administrators, GPA. Let's say prior to 2001, they had 500 clients. They had 500 plan documents out on the street.
Yep.
No telling how many hundreds of versions of the definition of medical necessity or the definition of experimental might have been in those 500 plan documents.
Right.
And so they were the first, at scale, they were the first TPA to buy into what Steve and I were doing. And the biggest reason they wanted to offer our model to their clientele is it identified clearly that they, GPA, were not the decision maker. So back to those 500 clients, if 300 of them, and that's about right, over time, bought our program, then you had 300 plan documents out there that were standardized and known to be lock, stock, and barrel Department of Labor and ERISA compliant.
Got it.
So they were very motivated to be compliant.
Got it. Interesting. So your epiphany, if you will, was to hire an ERISA attorney, get the language right, and create uniformity.
There you go.
So that across the board, anyone that dealt with you understood that your stuff was locked down, right?
Yes.
They were, I don't want to say bulletproof because anybody could sue anyone anywhere.
That's right.
Right. But they were in a much better spot than not having the protective language.
That's right. And so she gave us very tight language, like I said, medical necessity, experimental, illegal acts. These are where the large 7-figure claims are coming.
Right.
And those are the ones where the appeals cause angst and woe and stress and all that.
Right.
And so sooner or later, I know you're going to ask me, how did we get from making coverage determinations to reference-based pricing?
Yeah.
First of all, we never called it RBP. I think when the California retirement program got into it years later, that's where RBP was coined. But anyway, we were making only coverage determinations. We knew about the importance of canned and compliant and standardized language. And like I said, one of the bigger types of claims that we would see were experimental. And so, God forbid there's somebody out there who has cancer. We wanted, so that we could package the appeal up and send it to an independent review agency, we would gather all the information possible from a treating oncologist or multiple treating oncologists, the oncological hospital, so on and so forth. And we didn't mean for this to be the case, Ray. We were just asking for, why do you think this procedure ought to be covered? But what would come in would be shoeboxes full of bills, and we were seeing what they were charging for chemotherapy drugs, what they were charging for various and sundry other types of, you could look the drug up in Redbook or wherever and see the delta. Right. And so Steve and I scratched our heads and said, and this is in 07-ish, we said maybe in addition to deciding about whether or not this ought to be covered, we should also get into how much to pay for it. So we went to see the same ERISA attorney, and she said, you can do this, but it's this, you have to have airtight language. And I'll never forget it. The example she gave was on usual, reasonable, and customary. She said, you're going to want to make an argument that what the plan's going to pay here is a reasonable amount to pay. But if it's knee surgery, they're going to crank out the last 100 bills for knee surgeries, and they're going to say, this is what we customarily bill.
Right.
And now all we're doing is arguing. We're making money for attorneys, but not resolving anything.
Right.
So she said, just like I did for you, for your definition of medical necessity, definition of experimental, we're going to write very clear, clean cut language. We're moving totally away from usual, customary, and reasonable, and we're going to get into cost plus and Medicare plus. And so we called those metrics, or we called them starting points, bottom up pricing, the opposite of sticker price when you're buying a car.
Yeah.
But we never used we called it auditing a hospital bill. And later the coin or the phrase reference-based pricing came to pass.
Episode of Broken Healthcare Podcast is brought to you by Benefixa Healthcare Consultants. Visit benefixa.com to learn what's possible. Reduce the cost of healthcare for your organization, deliver better outcomes for your people, and yes, design health plans that give your people a path to $0 out-of-pocket costs for healthcare. Visit benefixa.com today. And back then, if we're talking cost plus, were you using Medicare as a reference point?
The original metric we used for a hospital was only cost, but very quickly, Ray, I mean, in less than a year, we realized there's business sense, there's legal sense, and then there's common sense.
Yeah.
Common sense wise, and in the court of public appeals, so to speak, you could never pay a hospital less than Medicare and have anybody that you stopped on the street think you paid them fairly. So we always were paying it cost plus, and then we put the counter measure in Medicare plus 20. And so Medicare plus 20 became the baseline. And if cost plus 12% was higher, we paid that.
Got it. And so just to cut to the chase, because there are people listening to this, they may be physicians and hospital administrators, and there are those that will argue that they lose money on the Medicare reimbursement rate. What would you say to that?
I guess some do. I know that when I ride down the interstate in Florida, I-4, I-75, the Turnpike, there are a lot of billboards advertising for Medicare patients. That's what I know.
That's true.
Yeah.
We have them here too.
Yeah.
Yeah, I would imagine, especially in Florida, though.
Right.
Yeah, it's a good point. And so what Woody is talking about, folks, for those, who may not be familiar with the vernacular, is really, I think, just common sense stuff, right? We shop price on everything. Pick a good, and you could say that Amazon and Walmart are the retail giants. They're shipping stuff, and usually you're going to find excellent prices there. Not always, but most often they do a pretty good job. But you as a consumer are out there and you're looking. You're like, hey, I need a barbecue grill. Do I want a Weber? Do I want a Viking? What do I want? And what are the features? What are the costs? What's my budget? And you can find the same exact product, and maybe it's a $1,000 grill, and you could find it with a little bit of elbow grease for $700.
That's right.
Or you might spend $1,500 for a grill that's priced on average at $1,000. When we're talking about healthcare, it's so egregious, and when we talk about prices, you could pay $15,000 for a knee surgery or $150,000 for a knee surgery, and nobody's paying attention. Everybody is focused on what? What would you say they're focused on?
usually their aunt said they had a good experience at this hospital or this doctor. I mean, there's not enough focus. There's not a lot of focus
on the quality care, but monetarily they're focused on what they're paying,
yeah, they're out of pocket.
what their out of pocket is.
That's right.
And it's the wrong thing to be focused on.
Well,
right?
though, except
Yep.
unfortunately these days with out of pockets being as high as they are, I get a blue collar person who makes $45,000 a year wants to know where in this $7,000 where do I fit?
100%.
I mean, because we've priced these people out of the industry's priced them out of the ballgame.
Completely.
Yeah.
Yeah. There's, if you take someone that, is, making $30,000 to $50,000 a year, it's not a lot of money these days. No. And so now if you're talking about them having to come up with $3,000 because they have a deductible to meet, that's unaffordable. They're functionally uninsured. And so
functionally medically bankrupt is what they are.
Correct, because we know that they can't afford it.
Right.
They need a procedure that they medically have to have. It's necessity. It's not, I laugh when I, talk about, consumer-driven price plans and high deductible plans and how they're going to stop all of the people from rushing to the doctor because it's so fun to go to the doctor's office.
And it's so efficient.
And spend money. It's just only the major insurance carriers could come up with this. But ultimately, people aren't, generally abusing the system. And so when you throw a high deductible, when you put a high deductible plan in place as a mechanism to control costs, it's a really poor way of going about it because, the masses aren't rushing to the doctor to have XYZ procedure. But when there is a need for there to be a procedure that has a ticket price, maybe even a cash price of $3,000 or $5,000, the markup on that could be 10x easily in the regular system.
And back right to the very beginning of our conversation here, when insurance fundamentally is for catastrophic events. I understand the high deductible on paper was designed so that the member had a little skin in the game for routine care, but it's had the unintended consequence of having them delay care of the catastrophic nature, which longer term costs the whole system more.
Absolutely. It's just it is a rigged, broken system.
That's right.
And it's one that has people distracted instead of having them focus on really the two metrics that count, and that's the quality of the provider and the setting that their procedure is going to be taking place in, and the cost, the actual true cost. Right. Where I started my insurance career with Aflac, and at Aflac, you're selling folks products that pay them cash in the event of sickness or injury so they can afford to keep their head above water and pay their bills and their everyday living expenses and let their health insurance do what it does. And I used to manage a pretty good sized team, and we used to close business and close accounts, and then we'd send our agents out to go and service the groups and meet with the employees and write the business. And these people who, were part of my team and I felt responsible for them, and not to bash Aflac or the folks that I had the honor and privilege of serving and managing, there were inevitably some people that would always argue about the split. They were concerned about what their share of the split was going to be. And I just used to laugh. I used to bring them in and I say, let me ask you a question. If I tell you that you get 90% of the split, but you're going to take 3 applications and you're going to make $50, or I tell you you're going to take 10% of the split, but you're going to write 1,000 applications and you're going to make $5,000, what do you want? Right. What split do you want? And I'm telling this story because I feel like that's our healthcare system at work. It's not we're not dealing with real money. It's a casino. And people are playing with chips. And that's the way the insurance carriers like it. They want people to be focused on what their share of the out-of-pocket costs, they don't want people to ask the question, what's the cash price? And I don't know if you agree, but I think that's the one single most important question. If we get people into the rhythm of asking that question, I think it's going to open a lot of eyes. And that's whether you can afford it or not, or whether you pay cash or not. And even if you have insurance, by the way, if I pay cash, what's the cash price?
Right.
Right? Would you agree?
It would be, on the one hand, Ray, I would agree. If you could get there, it would make a big difference.
Right.
But getting there, there's ways to go. Yeah.
No doubt. Well, and so that's where your experience comes in. So talk to us a little bit about kind of the early days. And, you know, you and your partner came up with a great idea. You saw a gap. You saw a need. You saw a hole that needed to be filled. And you were fortunate to find what sounds like a very savvy, good ERISA attorney, which are not easy to come by.
No, not at all, because it's very much a specialty.
Correct. And so it sounds like you got some great advice and counsel there, and that led to you being able to assure your partners that they were in good hands dealing with you.
Right.
And you were primarily working with TPAs back then, or what?
Well, there was the very first client we ever brought on into the new quote unquote reference-based pricing schema we were working with some TPAs in that covered program. We charged a modest PEPM. We became a co-fiduciary to the plan. We'd set your final decision up through the appeals process, access an independent external review for you, then own the decision. In that model, we were working for TPAs, and the very first prospect we had in the payment model, at the broker firm I used to work with, a friend of mine who was a producer, you know, had a client in Valdosta, Georgia, still a client. So the Langdale Company, right east of the Mississippi River, and not counting government landholders like federal parks and national, state parks.
Yeah.
They're the largest landowner east of the Mississippi River. Pine trees.
Wow.
So they cut a pine tree down, plane it, turn it into a 2x4 or a piece of plywood, sell it to Home Depot, start all over again, replant the pine tree. This producer friend of mine, I ran this idea by. He's like, I got a woman who'd be interested in this. And so Steve flew from Philly and I drove from Atlanta, and we rehearsed this pitch up one side and down the other. And the one thing we didn't rehearse is that she would actually say yes. You know? So I mean, we laid out, we want to do this on a cost plus basis. We'll take the responsibility from you. And there had been a car wreck.
Yep.
And there was a young fellow had been in ICU at the University of Florida Hospital System in Gainesville.
Okay.
And it was a large claim. She said, it's new, it's right in front of me, and if you want a pilot project, here you go. And if we're happy with one another's work here, I'll be your client. And away we went. And that was in the fall of 2007. Here we are in 2025, and she's still a client.
Wow.
And she went on to become the first self-funded plan to sit on what's now known as a reference-based chassis in the country.
Wow. That's a great story.
Yeah, everybody, if you get one client like this in a lifetime,
It's a game changer.
That's right.
Yeah. So unpack this for me a little bit, because it's a little abstract to me, and I'm sure for a lot of our audience, it's abstract. So first, I don't know what your thoughts are on the words level funded and self-funded, but I hate those terms because it's kind of like insurance vernacular and all the acronyms we have.
And there's way too much of that.
Is way too much of it. And so I think when the uninformed CFO hears the word self-funded or level funded, most of them, being conservative folks, are thinking that sounds risky. Mm-hmm. And so I am adverse to risk, therefore I don't want it. And it sounds to me like what you figured out was a way to de-risk the plan and take on or assume responsibility. But I wonder if you could break that down for me and for our audience, just in terms of what does an employer need to understand about moving away from a fully insured policy where the insurance carrier assumes all of the risk to a level funded plan where now the employer's plan sponsor is essentially the insurance carrier?
Right.
And prior to you and your partner putting this together, what did their risk look like? And then after you put together what you put together, what did the risk profile look like?
There was a lot there. So I do like, you had our CEO, Jeff, back on the show a couple of months ago.
Yeah.
And
Jeff was great.
I listened to one thing you said to him, which is your theory was that if a company wants the most expensive commercially available option on the market, then get yourself a fully insured plan. So
I stand by that.
I wholesale agree. And so this all comes down, in my humble opinion, Ray, to defining risk, to appetite for risk, and then I wouldn't even call it sophistication, just enough curiosity to peel a couple of layers of onion back. And so on financial risk, like you said, a fully insured commercial plan, it's already the most expensive option out there.
Yep.
And we're in the renewal season right now for January 1. You're a broker. You tell me what's the average renewal, increase you're seeing.
Double digits, baby.
There you go. And so I've got something that I know is overpriced. It's going up by 10 to 20% this year.
Or more.
How many more years am I able to absorb that financial risk? So we're already dealing with financial risk.
Yeah.
And so then, how do I so if and I am a business owner, if I have something that's it's the first or second or third largest expense on my P&L.
Yep.
I have no idea why it's priced the way it is. So I'm already
in the dark,
bringing on risk.
Yeah, sure.
Right. Yeah.
Right.
And then it's going to go up 10 or 20 or 25%. How can I say that that's some safe haven?
Yeah.
Like I'm duty bound, I think, to explore other options. And so there is some risk in being self-funded, moving away from that fully insured model. But as you know, you can play stop loss around that and limit the risk. And so I think it takes a fairly tunnel visioned, closed-minded, honest to God evaluation of the situation to say that there's financial risk in being self-funded.
Right.
And so then once you move to that peeling back layers of the onion, our program is very, Ray, paint by numbers. To say this is one of the misnomers or misunderstandings in the business, to say that the government has not provided enough oversight and regulation, to me, that's one of the worst jokes out there. So in 1974, which,
ERISA.
Yeah. It passed. It has one fundamental obligation that jumps off the page and is the foundation of our program, to pay only the reasonable cost of administering and operating the plan. So if I don't want to pay something that's been inflated till 10 times Medicare, I don't have to.
Right.
I've got an obligation under federal law to analyze that transaction and build my plan around something that allows me to pay a more affordable rate.
Yeah.
And so there's more in ERISA, and then there's HIPAA. You can roll all the Department of Labor Act I mentioned that passed in 2001, became law in 2002 and 2003. It was a great law. And then here lately, in the last 3 or 4 years, the CAA and the Transparency Act and the No Surprise Act.
2021.
Yeah, the federal government has literally given a self-funded plan sponsor and its business partners, people like you and me, a recipe to follow on a paint-by-numbers basis. And I think so there's not just financial risk, there's operational risk or legal risk or whatever. But if you follow the process and document it in the plan document, and then everything you do on behalf of the plan tracks back to the plan document, you can limit the risk to almost nothing.
So it's kind of my contention that if you're in a properly structured level funded plan or self-funded arrangement, you're inherently less risky than being in a fully insured plan.
And I would say exponentially more compliant.
Mm.
And if you're and of course, I think you and I are making one presumption right now. If I'm self-funded, but I remain with one of the BUCAs, with Blue United, so then I'm self-financed.
Right.
But I'm in the same old standard operating protocols of Blues or Uniteds. I'm bankrolling all this.
Yeah.
But I haven't done much to mitigate my risk. I've just changed who's paying for it.
100%. And so that's what I think folks have a hard time with. Even folks that are, tenured HR professionals that have been in the business for years and years, and pick an acronym in the C-suite, right? They're folks that by and large are relying on their brokers for counsel and advice and putting them on the right path. And it is that IBM kind of adage, right? It's you never get fired for hiring IBM.
Right.
And so if they're one of the big houses that are publicly traded or even the big privately held brokerages, they feel like they just can't possibly be doing better for their organization and their people, when the reality is just so starkly different from that. And
Right.
it's I have a really tough time just kind of swallowing this anymore, because it's just so apparent that they're going down the wrong path. And if you've been drinking the same Kool-Aid for 20 years and you drink it tomorrow, it doesn't mean that your Kool-Aid's not laced with arsenic.
Right.
Well, maybe it does if you're still alive, but you're sick and you're ignoring it. You're refusing to, at the very least, Woody, I think you're refusing to inspect what you expect, and you have a fiduciary obligation to do so. And what we're talking about is, well, if you ask your broker to run your top pharmacy drug spend, and you compare that with a fiduciary pharmacy or PBM, and line item by line item as you go down, I paid $1,500, I could have gotten it for $25. I paid $4,000, I could have gotten it for $300. I paid $60,000. I could have had someone on the patient protection program, federally funded, and paid zero to us, zero to the patient. And if you don't know what I'm talking about, and you're in I'm not talking about you, I'm talking about some of our listeners that hopefully are here trying to get a handle on this. And I'm not proclaiming to know everything, and I don't think you are either. But you owe it to yourself to at least take a listen and ask yourself, well, 3,000, 5,000, 60,000, these numbers start adding up, and you're knocking yourself crazy. You have a purchasing team that's, scouring the earth for savings. And here you have a healthcare budget, which to your point is one of your top 2, 3, 5 P&L expenses.
It's 2 or 3 almost every time.
After payroll, right? And you're not looking at it.
Right.
Like, what is going? Is it really? So this is a question kind of in jest, but is it the sending of the CEO and the CFO to the Masters and to Pebble Beach and flying them on a private jet and putting them on a cruise, or am I so jaded and so far off the mark that these folks are just like, oh, the perks are going to disappear? And I hate to think that, because when we're talking about the plan dollars that are at stake, they could friggin' buy themselves a private jet in some of these cases.
Yeah, I think that they in your story are the big broker firms, but Ray, they bear some responsibility in my opinion, but there's supply and demand. The broker firms are on the supply side, as are the four big insurance companies, as are the 3 big PBMs, which have 80-something% of the market share.
85.
Yeah, and then you got the whole universe of large hospital systems and physician practices. That's the supply side.
Yeah.
And the way the transaction happens right now, on the demand side, the demand side could be defined one of 2 ways or both. It could be the commercial health plans, the ABC manufacturing company who
Yep.
sponsors the plan. So they're a purchaser. Or it could be a member of that plan who's a healthcare consumer. This person, she has to go to the doctor, she has to pay her out of pocket. There's been a certain completely untransparent, completely unfair, completely rigged way in which each one of these transactions goes down the past 30 some odd years, where I'm going to buy it and I'm going to pay for it, but I don't know what it costs and I don't know if there's any quality until after I've already used it.
Right.
Well, fool me, what is that saying? Fool me one time,
Cut me once, shame on you. Cut me twice, shame on me.
If I've been paying for this BS for 30 something years and hadn't done anything about it,
Yeah.
we can't, you and I, as much as it feels good, we can't necessarily castigate the supply side for it.
Right.
Sooner or later, the demand side has to say, I'm not taking it anymore.
Agreed.
Yeah.
Agreed.
All right, that's a wrap. Hit like, follow, and subscribe, and we'll catch you next time.